بسم الله الرحمن الرحيم. اليوم حنتكلم على موضوع كتير الحقيقة مهم regarding the anatomy of the heart بصورة عامة يعني حنتكلم على the microscopic features or structures of the heart wall and its related structures like the heart valves and related clinical implications for that. We are having a cut section in the heart wall. It is composed of three main structures. The epicardium, the outside structure uh, of the heart wall, which is the visceral pericardium. And the visceral pericardium, as we know, it is the innermost structure of the serous pericardium. We know the pericardium is of two main structures, the fibrous pericardium and the serous pericardium. The innermost structure of this one is the epicardium of the heart. The second structure going in is the myocardium itself, the cardiac muscle itself. The cardiac muscle layer forming the main bulk of the heart, whether in the atria or in the ventricles. The atrial walls, generally speaking, are relatively thinner than the ventricular walls. Both the atria and ventricles are separated by a septum. If it is in between the atria, we call it as intra-atrial septum, and in between the ventricles, it is called as the interventricular septum. The uppermost part of the interventricular system is membranous-like, but the lower down one is the muscular part, for like the muscles of the heart. The smaller part of the interventricular septum, as we said, is the membranous one, and it is continuous really with the skeleton of the heart. This is giving relatively a balanced structure of the chambers of the heart. The innermost layer of the heart wall is the endocardium, which is the endothelial layer of the inner myocardial surface, and it is of it is clinically a very important entity because clinically we could have some sort of endocarditis. Then the muscle sometimes we are having myocarditis, and the valves in between the chambers of the heart. We can have some sort of valvular diseases secondary at least to infection. This is just an example for that. Let us have those structures of the heart from outer to inside one by one. If we are talking about the epicardium, the epicardium is equivalent to the tunica adventitia in the blood vessels. We know a blood vessel is having three layers: tunica adventitia, tunica media, and the tunica intima. Let us have some sort of similarities. The heart is the main vascular structure, and the blood vessel is, something, related to that. The outer layer of the heart contains blood vessels and lymphatics. Is some sort of, a blood supply and lymphatic drainage of the heart muscles. The fibroelastic connective tissue, the blood vessels and the lymphatics, and which was just, incorporating, covering or in between the epicardium coverings. The visceral layer of the pericardium is rather thin than the other layers of the wall. If we are talking about the myocardium, it is the main structure of the heart, and it is the thickest part of the layers of the heart. It is the middle layer of the heart, the thickest layer, containing the cardiomyocytes and the blood vessels for the blood supply and the drainage, supply and the drainage for that. It contains the cardiac muscle fibers, sometimes divided in parts, but uh, uh, like other muscle fibers. Uh, yeah, but the cardiac muscles are of certain characteristics. We know the types of muscles as we know before is either the smooth muscles or the striated muscles or the cardiac muscles. The cardiac muscles are characterized being striated but having the function of the automatic, like the smooth muscle in its function, apart from being branched, like not like the striated muscles of the limbs here and there, but it is some sort, it is branching, it is having intercalated discs, so it have its characters. You saw the cardiac muscles are having its own characters. It is equivalent to the tunica media, the intermediate layer of the blood vessel itself. Let us note that the cells of the myocardium are more branching than the skeletal muscles, the other type of the muscle cells, and it's striated, of course. The key feature characterizing the cardiac muscles are is in the dark links that run across the tissue between the cells, and those are the intercalated discs, which are very essential for the character of the contractility of the cardiac muscles. Very important to know this, and this is characterizing the cardiac muscles, and this character is not other muscles. The innermost structure of the heart wall is the endocardium. It's the inner layer of the heart, lines the atria and the ventricles, and cover the heart valves themselves, and contains some of the blood vessels. It's equivalent to tunica intima in the blood vessels. You see, there is similarity between the structure of the blood vessel and the heart, some sort to make it a little bit more understandable. This endocardium is having three sub layers, we call that. The endothelium itself, smooth muscle and connective tissue, and the subendocardial layer. For the endothelium, it is the innermost portion of the endocardium, and it is composed of simple squamous epithelium. But the smooth muscle and the connective tissue, this is the middle layer of the endocardium itself, is a type of mix of connective tissue and smooth muscle. The subendocardial layer, the outer layer of the endocardium, is loose connective tissue, and its main function, very important function really, is the joining of the endocardium to the myocardium so as to be complete integrity and as if one block working all together. It is very important for the integrity of the function of the heart muscle. Concerning the valve histology, what is the cusps or leaflets of the atrioventricular valves and the semilunar valves composed of? Generally speaking, each of the cusps of leaflets of the cardiac valves is formed of a fold of endocardium, as if fold, as if two layers, one to the atrial side or ventricular side, and one of the big vessels, either the aorta or the pulmonary artery. So a valve is a fold of endocardium and the connective tissue between them. Some connect, it could be different from one valve to another, but each valve, by the way, is having its own characteristics to its function in the cardiac cycle. Like, we know that the semilunar valves are not having chordiotensioni, but the semilunar valves are not having that. But the atrioventricular valve have the chordiotensioni being attached to the cardiac muscle through the papillary muscles. There is some collagen fibers. The attachment to the fibrous or skeleton of the heart makes a difference from one valve to another. If we are talking about the aortic valve leaflets, those are covered by a continuous layer of endothelial cells with a smooth surface towards the ventricle. This is the ventricle, smooth surface compared to the outer, to the side of the atrial side. Say, if we are talking about atrioventricular valves, it is irregular with some ridges. So the valve itself towards the atrium is a little bit rough with some ridges, but towards the ventricle they are smooth. And each of this characteristic is having some sort of its own function to let the blood being going through the atrioventricular valve or the aortic or pulmonary valve in a smooth and easy way. As we can see in here, the layers of each valve, as we said, we fold of endocardium, but the endocardium on the ventricular side is very smooth. On the inner side, it is some sort of some ridges or rough, a little bit, I mean. There are some layers in that. The endocardiac surface, which is being smooth, coming to the spongiosa, lamina spongiosa, we call it just next to that, the lamina spongiosa. Next to that is the fibrosa lamina أو بنسميها lamina fibrosa, and to the ventricular side, coming to the ventricular aspect of the side with completing or is just as if it is enrolling, going facing the ventricular cavity, in organized in a smooth way to let each valve doing its function according to its position and function intended to do. Its fibers tend to be arranged in whorls and spirals, and they have the property of spontaneous and rhythmic contractions according to the speed of the conducting impulse to going to each part of the heart. Specialized cardiac muscle fibers form the conducting system of the heart. So the conducting system of the heart are specific types of cardiac muscles that are intended and being structured to do the function of conduction of the heart impulses to the different parts of the heart. Cardiac muscle is being supplied by autonomic nervous system, like the vagus, which is slowing the beats of the heart, and the sympathetic nervous system, which is accelerating the beats of the heart. So the main external supply of the nerve supply to the heart is the autonomic nervous system, the vagus slowing the rhythm, and the sympathetic accelerating the rhythm. As simple as that, let us have it at this stage, this understanding of the cardiac muscles and their nerve supply. So the nerve supply is either external or autonomous, being paced by the conducting system. When we are going to explain it, so the conducting system being controlled by or being paced by the sinoatrial node, SA node, then going to the AV node, atrioventricular node, then AV bundle, then left bundle, right bundle to the different parts of the of. Uh, by the way, among the clinical entities, as I have mentioned concerning the linings of the epicardium or of the heart, like the endocardium. Endocarditis could be a big disease in the patient, inflammation of the endocardium. Still, there could be inflammation in the myocardium, myocarditis, secondary to certain diseases. We shall come across this in the coming years, and you will know that. But very important to know that the blood supply to the heart muscles are going to the heart through two main arteries coming from the aorta, the right and left coronary arteries. And if anyone or any branch of those arteries being blocked suddenly, there will be infarction or death, let me say, of that part of the heart muscles, which will cause clinically our patient will be presented by a picture of sudden chest pain, being sweating, being nauseating, and the pain having characteristics of, being retrosternal, radiating to the left shoulder, might go to the left upper limb, it might go to the neck, it might go to the jaw. And this is very important, looking to the type of your patient who could be predisposed to heart disease, infarction, I mean, like atherosclerosis or a heavy smoker. On that basis, if we diagnose such a patient and pick this patient up, we could save his life or her life if we are diagnosing in a better way. This is concerning and we shall talk about it in the coming lectures, really. This is for the sudden occlusion of an artery, but if it is a gradual occlusion of an artery, or there is a spasm, that's to say, there is decrease of the blood supply going to the cardiac muscle. And if decrease of the blood supply to the cardiac muscle, again, the patient will be having some sort of a chest pain, typical cardiac chest pain. By typical cardiac chest pain, we mean that this pain is retrosternal compressing. المريض بيجي بيقول كأني أنا حاسس على صدري فيه كأنه بلاطة كده في النص. Yes, to the left a little bit more, but it might be fully epigastric, it might be retrosternal, it might be radiating, as I have mentioned. And if we are diagnosing that, we could come to very important diagnosis and saving the lives. The last thing I'm going to talk about is those Purkinje fibers. And those Purkinje fibers, still those are specific types of cardiac muscle so as to convey the cardiac impulse or to do the conductivity of the heart. You know, as we know, the heart is pacing its contractility. And this Purkinje fibers has been discovered by Jean Purkinje really in 1839. And this Parkinji have some other authorities, like he described also the cells in the cerebellum. And in the cerebellum, we are having something in the brain, by the way, the cerebellum, Purkinje cells. But we are not talking about Purkinje cells now. We are talking about Purkinje fibers, which are the terminal ends of the conductive system of the heart, reaching the target areas to be, to be activated and to contract secondarily to that. So Purkinje fibers are modified cardiac muscles compared to the ordinary cardiac muscles. They contain large amounts of glycogen. They are fewer myofibrils. They are thicker cells than other myocardial cells. Can be binucleated. That's to say, it had two nuclei in each of the muscle spindle or cell. Each they extended from the atrioventricular node, AV node, and pierced the fibrous body of the muscle, dividing into left and right bundles and travel beneath the endocardium towards the apex of the heart, conveying the impulses to those parts of the cardiac muscle so as to contract or to complete the contractility. Bundle branches cannot contact cardiac muscle cells through specializations similar to something like intercalated discs, which are characteristic of the cardiac muscle. Purkinje fibers conduct stimuli faster. This is what distinguishes them from the usual cardiac muscles. So they are conveying the stimuli faster than ordinary cardiac muscle cells, about 2 to 3 uh, meters per second versus the point 0.6 meters per second as compared to the cardiac muscles. For clinical implications, any interruption of the conductivity of the heart, it could put the heart in some sort of a certain degree of a block. And clinically, we are differentiating or classifying the blocks in the heart like first degree, second degree, or different types up to complete heart block. Yes, there is right branch block, there is left branch block, but any damage during the passage or the journey of the journey of the impulse through the Purkinje fibers, we could have some sort of a block according to the site being affected. Just to have a rapid look, we shall have complete lecture and complete explanation about the conducting system of the heart, but just for us to be oriented now with the conducting system of the heart, it starts here in the right atrium, the secondary, just near the opening of the inferior vena cava here and between the inferior and superior vena cava really. And we are having the SE node, we are having some fibers connecting both atria together, then coming the AV node, coming the bundle of his here, AVB bundle we call it, then right branch within the left branch is here, and they are ending by the Purkinje small fibers to have the conductivity in a peaceful form and normal function of the heart. We shall have this in a complete explanation in the coming lecture, inshallah. Thanks a lot. Please any question, I am ready for everything. Of course, those lectures are intended, to refresh you, to start you, to let you go and read. It is not exclusive. Please go for your textbooks of anatomy to read more and to gain more, and let us discuss things together. Thank you.